Good morning and good afternoon. I am Yousef Khader. I am a professor of epidemiology and biostatistics at Jordan University of Science and Technology. And I'm the technical advisor at the Eastern Mediterranean Public Health Network. And also I work as the director for the Center of Excellence for Applied Epidemiology at Infinite. It's really great pleasure now, to go with the session number 5 on communicable diseases, where we will talk about two important areas. The first one is in human brucellosis, and the second one in infection control. Before I invite the first speaker, please remember to use chat box feature to post any question. Now, the first presentation will be on detection and molecular characterization of human brucellosis in southern West Bank. So I'm glad to invite Dr. Yaqoub Alashhab, who is going to present on behalf of Dr. Bessan Aljanazreh. Dr. Yaqoub is an associate professor of molecular biology and bioinformatics at Palestinian Polytechnic University. He's currently leading a national project to establish the Palestinian Korea Biotechnology Center. His main research interests are designing novel vaccines and point-of-care testings to help fighting brucellosis. Yes, Dr. Yaqoub.
Hello, my name is Yaqoub Alashhab, and I work at Palestine Polytechnic University in Hebron. Strikingly, Hebron, which is a relatively small city, used to report incidence rates of brucellosis, which is a zoonotic disease, more than all European countries together. Therefore, I'm here today to present the results of our project that aimed at studying brucellosis in Palestine, and specifically in Hebron Governorate, after the year 2012. Brucellosis is caused by a bacterial genus called Brucella. This genus belongs to the class Alpha Proteobacteria, and it has 10 different species that are classified based on their primary host preference. Domestic mammals are considered the primary hosts of the most well-known zoonotic species of this genus, including Brucella militensis, Brucella abortus, and Brucella suis. The three Brucella pathogens are usually transmitted from animals to human via ingestions of unpasteurized milk or dairy product. Brucellosis has large impact on livestock sector as it causes abortion, infertility, and reduction in milk production. In humans, the disease causes a serious infection with various symptoms, including indolent fever, joint pains, and less frequently, some severe complications such as orchitis, endocarditis, and meningitis. Brucellosis is a global public health problem with high incidence rates in most developing countries. This map shows brucellosis incidence rates in the world. According to this scale, the countries in orange and red have high incidence rates, while the countries in green have low incidence rates, and the countries in white, such as Africa, have no data. Generally, a combination of two antibiotics, doxycycline and rifampicin, are recommended to treat human brucellosis for about 8 weeks. Unfortunately, a relapse rate around 15% has been reported in various studies. On the other hand, antibiotic treatment is not recommended at all for animal brucellosis. Typically, the infected animals are slaughtered to control the spread of the disease. In fact, there is no licensed human vaccine for brucellosis. And the most effective way to control brucellosis is by vaccinating livestock. Currently, there are 3 licensed vaccines for livestock. The 3 vaccines are actually live attenuated Brucella strains. Rev1 is a Brucella militensis strain that is used to control brucellosis in small ruminants, while S19 and RP51 are Brucella abortus attenuated strains that are used to control brucellosis in cattle. It is important to mention here that transmission of Rev1 strain from vaccinated animals to human can cause typical brucellosis. Let us have a look at the human brucellosis figures in Palestine. As you can see, before 1998, the annual incidence rates of brucellosis in Palestine used to be very high, and specifically in Hebron region. However, and after the implementation of a brucellosis control program using Rev1 vaccine to massively vaccinate small ruminants, the incidence rates of human cases showed a significant reduction with relatively stable rates until the year 2012. After 2012, the disease started to re-emerge, and again with the highest incidence rates in Hebron region, and reaching its peak in 2016. Therefore, in this work, we sought to isolate and characterize a group of strains associated with this re-emergence and to investigate the possible reasons behind this re-emergence. This and the next slides show our sample collection and analysis methodologies. During the period between January 2015 to April 2017, we analyzed 1,324 blood samples from suspected patients. All the experimental procedures and data analysis were ethically approved by the Ministry of Health. For initial screening, the Rose-Bengal serological test was performed, and positive samples by this test were examined by serum agglutination test for confirmation. Only confirmed seropositive samples from patients not on antibiotic treatment were further cultured using BACTEC blood culture system to isolate the pathogen. Genomic DNA was extracted from positive culture, and the DNA samples were analyzed using 3 PCR assays. The first was to validate the presence of Brucella bacteria. The second was to identify the specific Brucella species. And the third assay was to rule out if some of the cases were due to infection with Rev1 vaccine strain. We then used the assay called MILVA16 to determine the specific genotypes of all the isolated strains. Furthermore, we sequenced the RPO-B gene from 9 suspected isolates by next-generation sequencing in order to screen for any rifampicin-resistant associated mutations. Now, let us see our results. Out of the 1,324 suspected blood samples, 704 were positive by Rose-Bengal test, as you can see. And of these, only 559 samples were confirmed to be seropositive by SAT test using a titer of 1 to 80 as a cutoff. Unfortunately, only 130 samples were suitable for blood culture, as the rest 429 samples were from patients who were on antibiotic. This slide summarizes the results of the molecular identification tests. Of the 130 seropositive samples, 72 showed positive blood culture that have Brucella. When tested to identify the associated species, all the 72 strains were Brucella militensis. And when tested for possible involvement of Rev1, none of the 72 strains was related to Rev1 vaccine strain. A careful analysis of the results of the 559 seropositive samples point to some interesting points that deserve further investigation and discussion. The first point is that about 76 of the patients, showed here in gray as you can see, were on antibiotic treatment before a definitive diagnosis, which indicate to a serious misuse of antibiotics. The second point is that significant percentage of our patients had high titer at initial diagnosis, as you can see in the last 2 or 3 titers, including some titers 1 to 1,280 or even 1 to 2,560, which is a very high titer. And this indicates a late diagnosis problem for brucellosis patient in Palestine. The third interesting point is that out of the 130 cultured samples shown here in red, as you can see, only 72 were successfully isolated by blood culture, shown in green. This denotes the low success rate of blood culture for diagnosing brucellosis. Coming to the RPOP sequencing analysis, we sought to screen for mutation in the RPOP gene that could be associated with rifampicin resistance. This is, as you can see, the RPOP gene, and these are the 2 rifampicin resistant determining regions. The lower part shows the binding site of rifampicin molecule, shown in green, and the corresponding amino acids within the RPOP protein. Analyzing the 9 suspected isolates, no one of these isolates has rifampicin resistant associated mutations in the rifampicin resistant determining regions. However, this does not exclude the possibility that mutations in other genes could be associated with rifampicin resistance. We then decided to evaluate the genetic relatedness of our strains in comparison with a group of global strains. Using the MELVA bank server, we compared the MELVA 16 results of our 72 strains, here shown in light green, with a group of 73 global strains with known MELVA 16 profiles that represents the 3 major geographical clades. The Western Mediterranean shown in blue, the Americas shown in red, and the Eastern Mediterranean shown in dark green. The analysis demonstrated that our strains are indigenous strains that most likely took the opportunity to spread among the local livestock herds and then to infect humans. Finally, we decided to compare the incidence rates data that was reported by the Palestinian and the Israeli Ministry of Health. Similar to the high incidence rates that was recorded in the southern part of West Bank, high incidence rates shown here in red dots were also recorded by the Israeli Ministry of Health among Arabs who live in Al-Naqab, Negev region. It is important to recall that the 2 Arab societies across this border have strong socioeconomic relationships. Going to the incidence rate curves for the 2 regions, we can see very strong harmony of the re-emergence of the disease. Several reports pointed to obvious deterioration in the Palestinian and the Israeli brucellosis control program, including budget reduction and serious interruptions of animal vaccination campaigns. Altogether, our findings underscore the importance of adhering to brucellosis surveillance and control plan that must involve all stakeholders. For the conclusions, I would like to focus on 3 major points. The re-emergence of brucellosis after 2012 was likely due to some quiescent Brucella militensis strains that have been lurking in nomadic herds of sheep and goat or maybe camels. The deterioration in brucellosis control program is most likely the reason for the congruent re-emergence of the disease. And finally, based on our findings, we believe that a national diagnosis and antibiotic treatment guideline to meet the local context of this disease is highly needed. Thank you for your listening, and I would like to thank my team, Bessan, Khalid, Asma, and Mohammed.
Thank you, Dr. Yaqoub. Really, it is very interesting presentation on molecular epidemiology of brucellosis in Palestine, and thanks to your team too. Before I introduce the second speaker, please be reminded to use chat box feature to post any question. It was really very interesting presentation, and I expect to see more questions on this presentation. Now, I'm very glad to invite Dr. Mohammed Lubbad to speak on the adherence to CDC infection control guidelines in hemodialysis care unit at Shifa Medical Complex, Gaza Strip. Dr. Mohammed, he is a graduate of the Islamic University of Gaza. Yes, Dr. Mohammed.
Hi everyone, Assalamu alaikum. Our presentation today will be adherence to CDC infection control guidelines in hemodialysis care unit at Shifa Medical Complex in the Gaza Strip, which is a clinical audit. Infection is the most common cause of hospitalization and the second most common cause of mortality among renal hemodialysis patients. They have increased risk of infections due to frequent use of intravenous cannulation or catheters. This audit assesses the current clinical practice at one hemodialysis units in Gaza Strip with Center for Disease Control and Prevention, which is CDC guidelines, to implement an aseptic approach when dealing with hemodialysis catheters and hemodialysis patients. As methods, which is a clinical audit, was conducted at hemodialysis unit of Shifa Medical Complex. The data was collected in 4 major groups. Hemodialysis catheter connection and disconnection. The sample size for this group was 100 patient. Hemodialysis exit, catheter exit site care, 50 patients. Dialysis station routine disinfection, 20 visits, and hemodialysis injectable medication preparation and administration the sample was for 100 patients. The data collection sheet was adopted from CDC guidelines, and data were collected between April and November 2018 by direct observation of care. This slide, or the first group about hemodialysis connection and disconnection, this slide for hemodialysis catheter connection. The second one, or the next one, for catheters disconnection. These items are copied literally from the CDC checklist for hemodialysis catheter connection. And we observe the practice and compare the practices by the guidelines, the CDC guidelines. So we found that wearing mask and hand hygiene was 0%, put on new cleaning gloves 3%, clamping the catheter and removing caps from the catheter which will be connected to the bloodlines was 98%, scrubbing catheter hub with antiseptics 5%, allow hub antiseptic dry 3%, connecting catheter to bloodlines aseptically was 73%. Here is a gap of 27% in this item or this section. Removing gloves, performing hand hygiene after the connection, 0%. For hemodialysis catheter disconnection, wearing mask, 0%, performing hand hygiene, 3%, put on new clean gloves, 25%, clamping the catheter and removing caps 97%, disconnect catheter from bloodlines of patients aseptically 58%, scrub catheter hub with antiseptic 3%, allow hub antiseptic dry 0, attach new caps aseptically for the bloodlines was 33%, remove gloves 14%, performing hand hygiene after the disconnection 0%. We noticed that put on a new cleaning gloves more than removing gloves. So the same glove in some cases the same glove is used for more than one patient. So the second group, the care of the catheter exit site at the of the patient, wearing mask if required 0, perform hand hygiene 2, put on the new cleaning gloves 2%, apply skin antiseptic 0%, allow skin antiseptic to dry 0. Don't contact exit site care after antiseptics 70%, apply antimicrobial ointment 0, apply dressing aseptically 80%, remove gloves 2%, perform hand hygiene after the care was 0%. As well, there is no applied skin antiseptic. This percent was just for don't contacting the exit site. Don't contacting the exit site. So there is a 30% of contacting the exit site with the by the health worker or by the nurses or doctors in the station. To be clear, just to be clear. Thirdly, or the third group, dialysis station routine disinfection. This group has two subgroups: before beginning routine disinfection and after patient has left the station. Here is the thing is mainly perfect. 100% for disconnect and take down, use the blood tubing and dialyzers from the dialysis machine, discard the tubing and dialyzers in a leak-proof container. Check that there is no visible soil or blood on the surfaces. Ensures that the priming bucket has been emptied. Ensure that the patient has left the dialysis station. Discard or single-use supplies. These items or these sections was done perfectly by 100%. But the main problem here, and in every group, as we noticed, in removing gloves, perform hand hygiene. Just 3% here. The second subgroup, routine disinfection of dialysis station after patient has left the station, wearing cleaning gloves 3%, 90% for applying a disinfectant to all surfaces in the dialysis station using a weapon motion with friction. Ensure surfaces are visibly wet with disinfectant, allow surface to air dry, disinfect which is 0, disinfect surface of emptied priming bucket, allow the bucket to air dry before reconnection or use 0 for 3% for removing gloves and performing hand hygiene. The final group also divided to two subgroups: hemodialysis injectable medication preparation and hemodialysis injectable medication administration. For medication preparation, the technique was done mainly perfectly, 100% for ensuring medication preparation area is clean. Inspect medication vial and discard if sterility is questionable, done 100%. Prepare medication antiseptically, 100%. Disinfect rubber septum of vial with alcohol. The rubber septum of the vial was done 1%. Withdraw medication from the vial using a new needle and the new syringe was done by 100%. Discard all single-use vials and store multi-dose or multi-use vials appropriately was done 100%. But our biggest problem here, performing hand hygiene, putting in new cleaning gloves and removing the gloves was not done at all. 0%. For injectable medication administration, the same problem, 0% for performing hand hygiene, 0% for putting on a new cleaning gloves, 0% for removing gloves and perform hand hygiene. But 80% for scrubbing injection port with antiseptic, attach syringe and administer medication aseptically, 80%. 100% for discard syringes after use, and our problem or our major problem here in the 4 major groups was performing hand hygiene, putting new cleaning gloves and removing the gloves was not done at all here. If we look for all the 4 groups, there is a major problem in wearing masks, hand hygiene, put on new cleaning gloves, and removing the gloves. There is a big problem. We know, or despite that, there is another problems, but the major problem for all groups or all sections was wearing mask, hand hygiene, removing mask. So, in some aspects of care, the staff showed a good adherence to guidelines, as we saw, such as in preparation and administration of medication and the cleaning dialysis machine surfaces and station. However, poor adherence fortunately was found in hand hygiene, wearing gloves, as well as application of aseptic dressings. Our recommendation, we recommend adopting the simple checklist of the CDC guidelines in the clinical approach of hemodialysis caster. So we will introduce this this checklist for the health workers and request to adopt those checklists, this simple checklist. The gloves, hand hygiene, and antiseptics are mainly and found in all stations, in all departments of the whole hospital, not just in this station. So it is not because of the lack of materials, because it is because of ignorance or less adherence to the little adherence to the aseptic techniques. To address the importance of hand hygiene and aseptic techniques in connecting and disconnecting catheter for nurses and workers, we suggested training healthcare providers according to the guidelines and performing an annual re-audit until the technique is adopted. This is the end of our presentation. I am so happy, I am so honored to present this clinical audit for you, and I will be more than happy if you have any question, comments, or edits to improve the overall aim of this conference or of this research papers as well. So thank you very much.
Thank you, Dr. Mohammed. It's really interesting presentation. It's really unfortunate to see the poor adherence to hand hygiene in this facility. In fact, hand hygiene is singled out as the most important intervention to prevent interventions. So we expect to see more interventions to increase the adherence of workers to hand hygiene. Now, thanks to both speakers, really very interesting presentation. Now the floor is open for questions. Please feel free to post your questions in chat box. Let me start first, Dr. Yaqoub. Thank you again. Really, this is very important problem. Actually, human brucellosis is really neglected health problem, and the reported rates actually are highly underestimated. So now we are witnessing re-emergence of human brucellosis in the whole region, not only in Palestine. The same thing, I know we have a problem here in Jordan and Iraq and other countries. So you mentioned in your presentation that this condition was controlled, but you saw a rise in the incidence of human brucellosis in 2015 and after. How do you explain this rise in human brucellosis?
Good afternoon, everybody, and thank you for giving me and my wonderful team, Bessan, Khalid, and Asma, this opportunity to present the data of our project that has been carried for the last 5 years. Actually, Bessan and Khalid are great master students, Asma and the technician. Let me go directly to your question, which is the reason. Actually, there are several explanations for this re-emergence, but specifically, the re-emergence of brucellosis in this region, specifically in the southern part of West Bank and also Al-Naqab region, seems to be related with the interruption that has occurred to the vaccination program. Let us not forget that the massive vaccination using Rev1 has to be carried every 2 years. I mean, it's a cycle of 2 years. In the first year, there has to be a massive vaccination of the goat and sheep, and in the second year, you have to vaccinate the young goat and sheep around 6 months old. And this program has to be supported on an annual basis. Unfortunately, since 2009, there has been interruptions of this program in the Palestinian region, with some years reaching to almost very low or zero coverage of the vaccinated animals. So when this is a population of highly turned over animals, we use these livestock for several purposes like meats and so on. So you have to vaccinate, you have to keep vaccinating, because you don't know if you still have a reservoir of some of these silent or quiescent strains somewhere in the nomadic herds or in the camels, or maybe in some of the animals in the wildlife in the region, because the region also contains other mammals from the wildlife. So you have to keep vaccinating to keep controlling these livestock. But we and also the society in the Naqab region, they witness the same pattern of re-emergence after 2012 and reached the peak in 2015 till 2017. And here I did not provide the graph that shows also the vaccine coverage. If you add the vaccine coverage graph to this graph, you can clearly show the strong relationship, the inverse relationship. I mean, once you start vaccinating and you decline in supporting the vaccination program, the annual vaccination, you will see the results of this like 2 or 3 years after you start. So it's not an immediate result. Usually you see the consequences of the deterioration in massive vaccination or in vaccination campaign after 3-4 years. And we have seen this in 2009. There are actually several reports from the Palestinian researchers, also from the Ministry of Agriculture, as well as some reports from the Israeli side showing more or less the same trend in deterioration and reduction, and sometimes even complete freezing of the vaccination program in some years, like in 2011, 12 and 11, I think. But you pointed to an interesting observation, which is the re-emergence of the disease in other countries also, in Iraq, Iran, and Jordan. Actually, I think the re-emergence of this disease in each country has its own circumstances. You know, it has to be studied very well, taking into consideration the vaccination program, as well as the socio-economic conditions, as well as the immigration, maybe climate changes. I mean, let me just give you 2 examples of re-emergence of brucellosis in 2 different countries. One in France, in the heights of Alps, and one in Bulgaria in 2003. Although they witnessed and they reported re-emergence in these 2 different regions in 2 different period of times, but the reason was totally different. One of them was in France, was related to the some of the mammals that are living in the Alps that they behave like they act as a reservoir of this bacteria, and you know, you have to keep control on your animals and their contact with the wildlife, with the wild animals, especially the animals in these mountains. While in Bulgaria, the reason for the re-emergence was the migration and the trade of live animals. So for each country, I think it has to be studied very well and very carefully, taking into consideration the different factors.
I totally agree. Thank you. Thank you for addressing this question. I don't see any comments, any questions. Shiraz, please help me if anybody is raising his or her hand. I don't see anybody is raising hand. If there is no question, I am also interested, Dr. Yaqoub, to know more about your efforts and your team efforts in designing novel vaccines. What have been done by your team?
Thank you. This is really an interesting question and very challenging question, actually. We have been working with the area of brucellosis vaccine for the last 8 years. First of all, we wanted to design some molecular biology techniques based on our bioinformatics expertise in order to be able to characterize the currently used vaccines and why they are acting like attenuated bacteria, especially Rev1. We have published some of our results in different journals. But now what we are using, we are actually, with the help of my team, and here I would like also to thank another member of my team, Yasmin Wake, who is not with us. She's now doing her PhD in Seoul in Korea, South Korea. We did in the last 3 years a kind of a reverse vaccinology approach. We designed our homemade reverse vaccinology approach. You know, reverse vaccinology is a very revolutionary approach of designing vaccines without the need of growing the bacteria in your lab. You know, Brucella is a biological hazard. It's biosafety. You need to have biosafety level 3 labs in order to work with it. and we don't have it, unfortunately. So we replace this with working with the genomes, with the sequences. So we have designed our own pipeline, bioinformatic pipeline of analyzing 90 different genomes that were available at that time in the in the gene bank, in the NCBI databases. And the idea was to find in this pipeline the most promising antigen candidates, to shortlist the candidates based on different, let's say, bioinformatic approaches. You know, it's a long process of genomic and bioinformatic analysis of of the whole proteomes of these 90 different genomes. We ended up having a small list of around 20 potential candidates, antigen candidates. And we are currently discussing the possibility of loading some of these antigens within an empty vector of salmonella that will be provided by Professor Roy Cortes from Philadelphia University in USA. And hopefully we will have also a collaboration with a Jordanian vaccine company, which is Jovac, which is a wonderful company in the region, in order to make the initial testing for this experimental vaccine.
Perfect, perfect. Thank you. We have a question from Dr. Haneen Edweib. Yes, Dr. Haneen, please.
Hi, how are you, everyone? Sorry, I missed part of the presentation. I had technical problems, but I have a question for Dr. Yaqoub about the problems and challenges that you usually face if you want to do like next generation sequencing. I know, like for my knowledge, that we don't have any infrastructure to do next generation sequencing currently in Palestine. And where do you do it? How do you manage to analyze the samples and to overcome these obstacles in terms of infrastructure? Because I'm interested in this because I'm in the biomedical sciences field. Thank you so much for your efforts.
Good. Thank you for the question. Actually, there are one or two labs that they can offer the services of next generation sequencing, but they usually offer this. One is Al-Istishari Hospital, I think. They have NGS, but only for exome sequencing. You know, it is only offered for patients who have some rare diseases. So they perform the whole exome sequencing. But in case you wanted to do something, I really recommend, before you plan to invest and to spend your money for NGS, you have to plan very well for your experiment, because sometimes we discover that we spend the money, we have a lot of data, but we don't know how to analyze them. We don't have a good question from the beginning. So I really suggest that you discuss this issue very well with somebody who have a good expertise in this field, because sometimes a good design of your work may save your money and may save your time, and also your capacity for analyzing. In our case, actually, we did not perform the whole genome sequencing for these 9 isolates, because we were only interested in targeted NGS for the RPOPG, which is a gene of about 5 kilobases. So what we design like small fragments of all that region, and we sent these fragments of the 9 genomes. I mean, together it was like one sample with indexing. We send it to a company in the Israeli side. Actually, since we merged the samples together with indexing, it was cheaper for us. And I would like to tell you that the price, maybe nowadays the price is even much less than when we did it in 2018. Now you can send your samples to some companies in South Korea or in China. There are some companies who are doing. Actually, I was amazed that 2 years ago I saw an announcement, an advertisement of a Korean company in the Black Friday. They offer transcriptome sample for $1,155. I mean, the NGS sequencing now is not becoming a big deal of making the sequencing, but I would strongly recommend that do your homework very well in designing your experiment, in asking a good question, because this may save you time and money and effort. And the most critical thing in NGS is the analysis afterward. I mean, here, fortunately, we have a good group of, my group is actually the most important expertise that we have is the bioinformatics. So we don't have problem in analyzing bioinformatic and sequence analysis. But in some cases, I guess that some Palestinian researchers, that one of the main challenges is how to analyze their results. I mean, there are different pipelines and different platforms, and usually they are not so easy. They are not user friendly for biologists or biomedical scientists. You have to hire somebody who is expert in bioinformatics. I think any one of us can learn this, can have some initial experience, let's say hands-on experience with some group or some of these online courses to do this, because this is, I guess, that the bioinformatics and playing with the data is the science of the poor people or poor countries or developing countries. I think this is the opportunity for us in Palestine to use more and more of these treasures in the public databases in order to generate knowledge.
Can I have another follow-up question? Just
Please.
quick one.
Go ahead.
My question also, thank you for addressing the first part, but the second part, have you find any physical difficulties in mobilizing your samples, or you're just depending on the Israeli part of analyzing? So are we still under siege, like biomedical sciences siege, in transporting our data and analyzing our data? Are we still depending on them to transport our samples? And is this task easy? Like, of course, nothing is easy in Palestine, but how difficult is this task?
Yes, I agree with you that we don't have the full freedom of moving as person or to transport our samples back and forth. And I have witnessed personally several problems with transferring or receiving samples. I remember one time I received some controls from Spain. They were lost in the airport for like 2 months, and once they reached to the DHL office in Hebron, they were open. All the tubes were open. So this is a problem that all of us face. Now, specifically for the NGS, for doing NGS, if you have the sample in Palestine and you would like to do the NGS in an Israeli company, the solution is that all the companies in Palestine, in Palestinian companies in Ramallah or in Jerusalem or Hebron, that they sell some of the running or the consumables. They have channels, like business channels with some Israeli companies. Some of them, they are even actually representing some of these Israeli companies. So you can rely on them as the mediators of either purchasing some consumables for you from the Israeli company, or moving your sample to the Israeli company, because they will offer you this service.
Thank you.
You will provide the sample to the Palestinian company, and they will send it to the Israeli company.
Wonderful, wonderful. It's really a fruitful session. Again, I'd like to thank both speakers. Thank you. Now, let us move to the second session for today on the effectiveness of medical procedures. The first speaker in this session is Dr. Wafaa Alzaanin. She will present on first complex maxillofacial reconstruction with the free flaps in Gaza Strip. It is a case series study from a place under conflict environment. Dr. Wafaa is a dentist and public health advocate. She's currently working in Palestine Children's Relief Fund. Dr. Wafaa's special focus is on children with craniofacial injuries and abnormalities. Dr. Wafaa.
Hello, everybody. It's my pleasure to be here today and present my abstract for Lancet Palestine Health Alliance 2020. I'm Dr. Wafaa Alzaanin from Palestine Children Relief Fund, PCRF, from Gaza Strip, Palestine. My presentation will be about the first complex maxillofacial reconstruction with the free flaps in Gaza Strip. This is a case series from a place under conflict environment. So let me just start sharing the presentation. Here we go. Facial defects or facial deformities cause impairments in appearance, speech, airway protection, support of the tongue, mastication, and even in respiration. These defects result from tumor resection, trauma, or congenital abnormalities. The preferred choice to achieve the best possible outcome for such cases in both adults and children is to perform maxillofacial reconstructive microsurgery with the free flaps, MRM. In normal setting, these procedures considered very difficult and sensitive in terms of their multiple steps, several requirements, and their needs for multidisciplinary surgical teams. So if this is the case in normal setting, how it would be in conflict setting? Well, several studies from different countries reported that it's better to not perform MRM in the host country where the foreign medical mission is working. They prefer to transfer the patient to the home country to have access to their usual settings to perform difficult surgery with demanding post-operative care. Their rationale is that it's better to perform in an environment that's known and mastered by the surgeons with the lower risks of complication and using reliable and high-end equipment. So it's true. It's exceedingly difficult to perform MRM in a humanitarian and conflict setting. In Gaza Strip, the main challenges that we faced were: number one, lack of training and experience among the local teams, especially surgeons and nurses. Two, shortage of equipment needed for the procedure. Three, the non-existence of a professional rehabilitation centers as appropriate. And four, lastly, the short period of mission. Mission's goal usually focus on dealing with more cases by way of shorter surgery duration instead of one long surgery. But some of Gaza Strip's patients stay in desperate need for such procedure. To the material and methods. In January 2017, a French surgical mission, mainly from head and neck reconstructive surgeons, served at Al-Shifa Medical Complex, SMC, to operate on children who need maxillofacial reconstructive interventions. The team served 5 missions in 2.5 years. The length of stay for each mission was 10 days. We recorded the demographics of the patients, their immediate pre- and post-operative and follow-up status, and the special consideration taken to perform the surgeries. Required microsurgical kits and sutures were not available at SMC. Instead, the foreign mission brought them with them. Also, surgical microscope was not available. Instead, surgical loops with a 3x magnification used, and intraoperative CT viewing was not available. This is a photo of the French mission. On the right side, is the head of the mission and the major surgeon in all the MRM procedure, Dr. Quentin Qasimiar. And on the left side, Dr. Nicolas, he was the anesthesiologist for all the cases. This is a photo after the first free flap. It was free fibular flap in January 2017. We performed it. We are both foreign and local teams here. Results. From January 2017 to March 2019, we performed 9 cases with MRM underwent MRM, we performed MRM for 9 cases. Here is the case summary. We performed MRM for 5 females, 4 males, 4 children and 5 adults. We performed 4 free fibular flap, 3 radial foramen free flap, 2 scapular free flap, and 1 thoracodorsal tab flap. Post-operative follow-up. The post-operative follow-up ranged from 5 to 12 months. Complication, 3 cases had complication, 2 on the recipient side and 1 in the donor side here. Case number 1 had sacroilious. Case number 4 had necrosis in the premaxilla after 6 months of the surgery. And case number 6 had donor side infection and it was controlled successfully. All the cases went to the ICU intensive care unit for at least 48 hours. For the facial contour, in all of our cases, we had a stable bony union and good to moderate facial contour. Average surgery time. The total surgery time was 12 hours, 2 for the anesthesia and installation, and 10 for the surgical procedure. For the rehabilitation, we performed acceptable rehabilitation despite the lack of a professional rehabilitation centers. After 6 months, the patient fully resumed normal diet without weight loss. They maintained intelligible speech and restored satisfactory masticatory functions. I'm going now to present some of the cases on you. This is case number 1. He is a 13-year-old male presented with a right mandibular swelling and facial asymmetry. Panoramic radiograph, as you can see here, revealed distortion for all the dental, for all the molars on the right side. This is the tumor after resection. We performed hemimandibulectomy. This is a view of the donor side fibula, where we harvested the free flap. This is a view post-operative after 2 years. As you can see here, the facial nerve is working very well and the patient is in good facial contour. Case number 4, she is an 8-year-old girl presented with longest-standing congenital, large and complete palatal fistula measuring 7 and 4.5 centimeter in the anterior palate. This is a palatal pre-operative view before the closure by radial foramen free flap, and this is a view after the closure and repositioning of the anterior teeth. Case number 6. She is a 3-year-old female presented with the largest swelling of the left lateral face. Clinical findings showed a large tumor of her mandible and maxilla with the involvement of her skull base and inferior to retroorbital region. Biopsy concluded to desmoplastic fibroma. The patient was referred 3 times to hospital in Jerusalem and Israel. However, no treatments nor surgeries were performed due to the large size of the tumor, young age of the patient, as well as the financial constraints. This is a view during the procedure and after resection the tumor. As you can see here, the facial nerve is preserved. This is after inserting the flap, tab flap was used. And this is a view after 2 years here. And here, before and after. Conclusion. We believe that reconstructive microsurgery can be safely performed in a humanitarian and conflict setting under some arrangement. First, effective management and coordination. Microsurgical expertise should be matched with coordinating the medical mission and selecting candidate patients for surgeries to be screened in the host country. Also, the foreign medical mission director must be an experienced microsurgeon in order to select the most reliable and simplest procedure. Our team was headed by an experienced microsurgeon working in a surgical center that deals with the numerous number of free flap cases. 2, availability of essential equipment and the duration of the surgery. The equipment should be readily available to the microsurgeons. In case the essential equipment were not available, foreign medical mission could brought the essential equipment with them, could be brought. The duration of the surgery, as I mentioned earlier, the duration was 12 hours to for the anesthesia and 10 for the surgery. The duration could be shortened by faster installation, nurses' training in reconstructive surgery and instrument required. Furthermore, modern microsurgical platforms such as intraoperative CT scans, 3D modeling, and prototyping ensure better cost and time effectiveness in the OR. Number three, the relatively high rate of infection is cited to be one of the major drawbacks in reconstructive surgery during a humanitarian mission. This relatively high rate could be attributed to the lower level of hygiene, suboptimal quality of cleaning services, in addition to antibiotic unavailability for prophylaxis. We control this risk by proper prophylactic antibiotic administration pre-operatively, or strict infection control measures and sterile environment, close follow-up done by the local surgeons post-operatively, and therapeutic empiric antibiotic available used as appropriate. Lastly, professional rehabilitation. Professional rehabilitation should be started as soon as possible to restore and improve functional and aesthetic outcomes for the patients. To reach successful outcomes, the rehabilitation requires close interaction among many healthcare disciplines. The main protocol for rehabilitation in Brucellosis is with implant-supported fixed denture. It can ensure result stability, reduce mucosal inflammation, and properly restore functional, mechanical, and aesthetic properties. In all of our cases, and despite their better prognosis and outcomes, especially in young patients, we were not able to use fixed denture due to financial constraints. Alternatively, we depended on removable prosthodontics. On the long term, further studies on the quality of life for those patients are needed. Thank you so much for listening for my presentation. I'd like here to thank BCRF and SMC for their logistic and practical support. I will be more than happy to hear all your questions in the discussion. Thank you so much.
Thank you, Dr. Wafaa. It's really very interesting presentation, and thanks for making me happy to see the last picture you showed for the cute girl pre and post operative. This is really very interesting. And I know I'm oral surgeon by training, so I know how much it's hard to perform complex maxillofacial reconstruction, especially in humanitarian and complex settings, not only for the procedure or the practice itself, but again for the availability of a professional rehabilitation that comes after the surgery. Thank you again. Now we will go to the second presentation in this session. Dr. Raed Tafish will present on Ondansetron for prevention of post-caesarean nausea and vomiting with spinal anesthesia. It is a randomized controlled clinical trial. Dr. Raed has a bachelor's degree in medicine and surgery from the Ukraine Medical Academy. He is specialized in anesthesia, intensive care, and pain management. Dr. Tafish is the head of obstetric anesthesia in Al-Hilal Al-Emirati Hospital since 2014, and he is a lecturer of anesthesia at the University College of Applied Science since 2014. Dr. Raed, please.
I am Dr. Raed Tafish, anesthesia consultant since 2010. I am working in Al-Hilal Emirati Hospital as anesthesia consultant and head of anesthesia and intensive care department. Our study about Ondansetron and the prevention of post-caesarean nausea and vomiting with spinal anesthesia. Randomized controlled trial. As you know, post-operative nausea and vomiting is defined as any nausea, retching, or vomiting occurring during the first 48 hours after surgery in patients. Post-operative nausea and vomiting affect between 20% and 30% of patients. As many as 70 to 80 of patients at high risk may be affected. BONV result in increased patient discomfort and detoxification, increased cost related to length stay. Post-anesthesia nausea and vomiting may be associated with more severe complications, including pulmonary aspiration, dehydration, electrolyte abnormalities, raised intracranial and intraocular pressures, wound dehiscence, esophageal rupture. The management of post-operative nausea and vomiting involve 3 steps. First step, risk stratification, prevention and treatment. Risk factors for post-operative nausea and vomiting can be divided to 3 categories. Patient's factor, surgical factors, and anesthesia-related risk factors. Patient's factors as female, gender, non-smokers, history of post-operative nausea and vomiting, history of motion sickness, dehydration, and gastric distension. Female gender threefold increased risk, has a threefold increased risk. And there are some associated risk factors, example, preoperative anxiety, ethnicity, decreasing age, and body mass index. Surgical factors include gynecological surgery, ENT surgery, ophthalmic surgery, intra-abdominal surgery, neurosurgery, and ingested food or full stomach. And associated risk factor as duration of surgery, increase in baseline risk of 59% per 30 minutes of surgical time. Anesthetic factors like general anesthesia, volatile anesthesia, nitrous oxide, perioperative opioid, neostigmine, and intraoperative hypotension. And associated risk factor like duration of anesthesia, supplemental oxygen, use of nasogastric tubes, gastric tube decompression. Management of post-operative nausea and vomiting include perioperative optimization, and we use APFIL score to assess and guide management of post-operative nausea and vomiting. APFIL score used for risk factor, female gender, non-smokers, history of BONV, post-operative opioid. Every factor 1 point. The sum is 4 points. Approach to therapy, firstly, prophylaxis. Prophylaxis according to the risk, low risk, moderate risk, high risk. Low risk, no risk factor, moderate risk, 1 risk factor, high risk, more than 1 risk factor. In patients who are at high risk for post-operative nausea and vomiting, most clinical use multiple 2 or 3 drugs to manage this complication. Nausea and vomiting are of the main post-caesarean delivery complication. Ondansetron is commonly used for the treatment of post-operative nausea and vomiting. This study aimed to define the most effective medication in the prevention of post-operative nausea and vomiting in women undergoing caesarean delivery with spinal anesthesia. Our study is a randomized controlled trial. Women undergoing cesarean delivery with spinal anesthesia were enrolled at Al Emirati Hospital, Rafah, Gaza Strip. Women were assigned either to take intraoperative Ondansetron 4 mg by intramuscular route directly after clamping of the cord, Ondansetron group, or without antiemetic medication, controlled group. Our primary outcome, nausea vomiting score using a scale of 0 to 3, 0 no nausea or vomiting, 1 mild, no treatment needed, 2 moderate treatment needed, and 3 severe, unresponsive to usual treatment and need multiple drugs. Nausea and vomiting score was recorded 1 hour after the end of the surgery, and then at 6, 12, and 8, 18, and 24 hours after the surgery. Use of other antiemetic medication after 24 hours and at the time to their demand. Secondary outcome, we measure occurring of headache after the operation, any recorded complications, time to past first flatus. Data were analyzed by using the K-square test and t-test in SPSS software version 22. A p-value of the less than 0.05 was significant. The study was approved by the Hospital Ethics Committee, and verbal informed consent was obtained from each participant. Our finding: in the current study, 108 women, 109 women were enrolled. In the Ondansetron group, 14 cases were investigated, while there were 69 in the control group. The cases did not differ in baseline characteristics, such as mean age, weight, duration of surgery. Ondansetron group versus in the Ondansetron group versus 31 years, in the control group 31.5 versus 31.4. Duration of surgery, the weight was 79 kilogram versus 77.9 kilogram. Duration of surgery 37.5 versus 38 minutes. P-value was 0.637. There were no statistically significant differences in NVS scale in the 24 hours after the operation. In the Ondansetron group, no cases needed an antiemetics medication, while 4 cases in the control group needed. Also, this was statistically not significant. P-value equals 0.121. Time to pass first flatus. In Ondansetron group, 14 hours versus 11.4 hours in the control group. P-value equal 0.038. The current study indicated that intraoperative Ondansetron was not associated with the prevention of postoperative nausea and vomiting. Further studies are needed to compare its effect with other antiemetic medications. Thank you.
Thank you, Dr. Tafish, for your representation. Unfortunately, Dr. Tafish would not be available with us because of an urgent matter in the hospital he is walking in. So again, the floor is open for questions and feel free to use the chat menu. If there is no question, I will wait actually for you to raise other questions or comments. I will take this opportunity again to come back to Dr. Wafaa. Dr. Wafaa, really nice presentation, and it raises many questions. So not a question, just a comment. I'm interested to know how cases of a cleft lip and a cleft palate are managed in Gaza. And I'm interested also to know your role in this mission. Please.
Hello, everybody.
Hello, Dr. Wafaa. Yes, we hear you.
So the question was how cleft lip and palate managed here in Gaza, and the second part of the question, what's my role in this mission?
Yes.
Okay. First thing, cleft lip and palate usually cases in Gaza depends largely in foreign medical mission. Mostly they come through BCRF. Like we can say, a small percentage depend on who are in, let's say, in emergency and with a very wide clefts and need it's like life-threatening for them. They have the surgery healed by local teams, but we can say like largely the procedures dependent on foreign medical missions. After the pandemic, there was severe gap and shortage in the delivery for their treatment. This is the first part of the question. For the second part, my role, I'm a surgical assistant with the foreign medical mission, and I'm a researcher with the BCRF. I work with the cases, I work with the missions, and I implement and conduct studies.
Thank you. Thank you. Any question? Please feel free to ask any question. Either you raise your hand or you post in chat menu. Okay, let me again actually. So I have plenty time to ask the questions I like to ask to Dr. Wafaa. What about the availability of the service of professional rehabilitation services? We know that such patients, they need, long-term rehabilitation. They might need speech therapy. They might need also replacement of teeth, prosthesis. So how these services are available, after surgery? This is one question. Another question, do you have in Gaza a qualified oral surgeon or maxillofacial surgeon to learn from this mission and to maybe in the future to do surgery independently?
Okay, so the first question, I'm sorry to tell you that the follow-up and rehabilitation services here in Gaza is kind of like not really transformed in a good manner. You know that the rehabilitation is a long procedure and need a lot of focus with the patients, especially with physical, psychological, functional, and dental. But after the mission depart from Gaza, not all the children have a proper rehabilitation and follow-up procedure. For me, from the BCRF, I tried to cover this gap by allocating 1 or 2 days in the hospital to volunteer and to follow up all the cases after the mission departure. But still, there is a shortage in this service, and there is no specialized oral physiotherapist or that kind of specialties that focus on the rehabilitation after the surgery on the long term, of course. For the second part, no, there is no program or residency for maxillofacial surgery here in Gaza, and there is no residency for oral surgery. Most of the dental graduate like work with their bachelor degree. So we have like not a lot of residents who are involving in this procedures and in the surgical treatment. Besides the treatment of cleft lip and palate, and it's as a result of the shortage in the number of oral surgeons, it's divided between the department of plastic surgery and maxillofacial surgery. One more thing is some of the cases with the cleft lip and palate need reconstructive surgery, and some of them need microsurgical reconstructive surgery. We try to cover that by training through the French medical mission, making microsurgical course for some of the residents, but they were not oral surgeons and not maxillofacial surgeons, only to try to cover this gap. So I hope that I answered your question and I give you like the details.
Thank you. In fact, you did. You answered my all questions. Thank you very much. Okay. Please, would you draw? I have a comment here. Okay. So I have a question or a comment from Dr. Chalmers. Would you like to speak, Dr. Chalmers, if you don't mind? You raise a comment. Yes, please, if you can.
Yes.
Yes.
Thank you, Dr. Khader, for the invitation. My question was, I found it difficult to believe that this was the first study of Ondansetron to reduce nausea after caesarean section. And what I was missing from the presentation was any reference to, let alone systematic review of, previous research addressing this question. My suspicion, because it's a common problem, is that that systematic review, the systematic review that is appropriate, both to save unnecessary effort and money, was probably not done. But I can quite understand if Dr. Tafish has had to go off to deal with a medical emergency, so he's not there to answer my question for himself. But I would want to draw attention to the general principle that new research should be based on systematic reviews of what is known already. Otherwise, it is, first of all, not scientifically grounded, as it should be, but also ethically and economically grounded, as it should be. Thank you for letting me comment.
Thank you, Dr. Chalmers. You know, really, we apologize. Actually, he's not available to address your comment, but I did a quick search on this topic. I totally agree with you. It is not the first study in this area. Multiple studies published. I looked at some systematic reviews actually. So there's, good evidence in this area. I shared the link with you with the latest systematic review. It says that there is convincing evidence regarding the prophylactic effect of at least 7 drugs they studied for post-operative vomiting, and still they recommend that there is, or they admit that there is still considerable lack of evidence regarding safety aspects that does warrant further investigation. In this study, Ondansetron actually is associated with decreased risk of nausea and vomiting. It's almost by 45%. The odds ratio, as I read here, it is 0.55, and the confidence interval is really concise. So again, it is not the first. Thank you.
Thank you very much. I suppose one could pose the question in the light of the additional information which you've provided, many thanks for that, that if a woman having a caesarean section was asked whether, on the basis of the evidence you've cited, she would like to have Ondansetron, I would be surprised if any woman said no.
Absolutely. I agree. I agree.
Thank you very much.
Thank you. Okay, I will not leave this without asking the question that I have in my mind to Dr. Wafaa about the large surgery that's done for the last lady. She looked very great after surgery. It's really ensured that the procedure was very successful. And really, it's very skilled actually to protect the facial nerve. So for those cases you manage, do you have an idea about trauma to facial nerve? Dr. Wafaa, you are muted.
Yes, I can hear you. But I did not understand exactly what about facial nerve.
Yeah, actually, I saw that picture. It was really big surgery, and you said that the facial nerve was preserved.
Yep. Yes.
What about other cases? Do any of those who underwent this procedure complained of facial nerve palsy? Because nowadays, actually, we see minor surgeries that are done, leaving this complication, nerve palsy or something like this.
Yes, especially if there were children, yes. So far, there is no any case had any facial palsy. We had another case like this one, but with large hemangioma, and also the facial nerve was preserved. And this is related to the skills of surgeons, microsurgeons who perform the surgery. So far, we tried to select the cases properly, and we did not have any case with a facial palsy. There's one case I can say that had this kind, but because the tumor was malignant and it had a complete neck dissection. So this is for all the cases.
Dr. Wafaa, actually, you describe yourself as a dentist and a public health advocate. For what you are, yeah. Would you please elaborate? What, how you link public health with dentistry?
How I link public health with dentistry?
Yeah, you advocate for what in public health? You are a dentist, so what area you work? Yeah.
Yes, I'm have a special focus for the children with the craniofacial anomalies and injuries. I connect maxillofacial surgery with public health through having programs and knowing about the most prevalent diseases and anomalies in the society, so I can implement projects that will target them and provide them with the proper surgical procedures, follow-up and rehabilitation. So in order to understand the proper treatment, I'm involved in maxillofacial surgery, and to understand how to implement the project, how to focus on vulnerable population and to provide them proper treatment, I'm also connected to public health. So I'm interested in public health with a special focus to deliver and help those children, because I'm here, I'm in Gaza, and I witnessed the suffer of those children through my work with BCRF, and I really would like to help them to receive a good treatment and to have a good quality of life and psychological well-being for anomalies that could be treated easily. So this is my my concern, and this is my goal. I'm actually I was accepted in Boston University to study global health, and with a special focus on the program that I want. And I'm now trying to finding help and collect all the money for my for my study to be there and to join in fall 2021. And after that, I hope to come back here in Gaza and start this project that will focus on the rehabilitation and follow-up services for children with the craniofacial anomalies. I would like also to focus on the war casualties, especially for children who had facial defects or facial gunshots and defects also.
Yeah, I hope that your dreams come true, actually. You know, just to mention that as I define myself, I'm, oral surgeon by training, but I did my public health, my degrees in public health. I was the first one in Jordan to do this. Now, I work in the Faculty of Medicine. Now, in the basic sciences and public health department, almost 90% of staff who, who have PhD in public health, anatomy, physiology, biochemistry, pharmacology are dentists, and they are really successful professors. Yeah. Thank you.
It's my pleasure. It's my pleasure to meet you and to meet someone like you. Thank you.
It's my pleasure too. I look forward to meeting you. Thank you.
Thank you.
Thank you all. Actually, it's really a fruitful and interesting session and discussion. I'd like to take this opportunity to, to thank the conference coordinators and all my lovely colleagues in Palestine for inviting me to moderate this session.